So let's start. Dr. Richard. Dr. Richard Blake will speak to us today about 3 real cases and the correlation of gait with biomechanical examination. It's okay, this, or Dr. Richard?
Hello, David. Yes, thank you so much for inviting me for Fixtoe to present these 3 cases today. My whole life is biomechanics. I work in San Francisco, and I've been practicing for almost 40 years now in both biomechanics and sports medicine. The presentation I'm going to do today will talk about just how to correlate what we see in gait to what we think about in terms of the overall biomechanics. And then, of course, we have to then come up with a treatment plan. So I'm honored to do it. I teach at the California School of Podiatry, along with Dr. Kevin Kirby, who I know you all know well. And we try to teach the students this thought process that I'm going to share today. So the first case is a patient who walks into your office and complains of lateral ankle pain and lateral foot pain. When you watch the person walk, as demonstrated by the first image, you'll see this heel contact supination that's occurring at the time that the foot should be pronating. So the foot should be internally rotating like this left side, and it's externally rotating or supinating. So what are our thoughts that could produce as the typical biomechanical treatments are deformities that cause this lateral instability. Can be a really high degree of rear foot varus, like genu varum, where somebody is very, very much to their outside of their foot. Also, number 2, these everted deformities, like foot valgus or plantar flex first ray or forefoot pronatus, that can cause this contact phase supination. It's supination out of phase, which is really terrible for the body. The third is in-toed gait, just somebody who has femoral anteversion real bad, or internal malleolar torsion, where they walk and there's so much on the lateral side that they can supinate, which is not a compensation. It's actually a very destructive force for them. The fourth type of person that may present like this is somebody who has an external angle of gait. It's typically, we see the shoes, when you're really externally rotated, the shoes can break down to the lateral side severely, especially if you add obesity, and just some people are very heavy walkers, and they can take a brand new pair of athletic shoes and within 50 miles have broken the shoe down, where now they can't wear them anymore because their legs start to hurt. And then we see all the time a history of ankle sprains. So many people, they sprain their ankle, it's not too bad, they re-sprain it, gets a little worse, they re-sprain it the 3rd time, they finally go to the doctor, and of course they're even worse if they have some sort of ligamentous laxity. So these people can just roll their ankles really easily after their first ankle sprain, where they lose the integrity of the ankle ligaments. And finally, the weak peroneal tendons. And of course, a patient can present with all these factors when you're working them up. So they can have weak peroneals because of a neurological disease, Charcot-Marie tooth or something. They can have just disuse from not using it after being in a cast for 3 months, or being sick with a virus, and old injuries can cause these peroneals to get really weak. So when we observe something wrong. In this case, it was the wrong timing of subtalar joint supination, and we have to figure out what the cause is in our attempt to fix it. We can't just put them in an orthotic and say you're fine, and that could be the worst thing for them, and which is the whole gist of this conversation this morning. It's like, okay, how do we think past just simple biomechanics and get a little bit more complex? So the answer for this patient was they had normal biomechanics. In fact, instead of a forefoot valgus, they had a forefoot varus. They did have a slightly lower angle of gait, so they weren't in-toed, but they were a little lower than normal. And that probably put a little stress to the lateral side. But this is one of my sports patients, very weak. Here's a young person who I could break their peroneal tendons with one finger. Their peroneal strength was so weak. And this is due to 3 recent ankle sprains and relatively no rehabilitation. Prior to being in self-quarantine with this virus, they just hadn't gone to the physical therapist to get a rehab program, or gone online and even done their own research. So each sprain with this patient was worse than the other one, and their peroneals just shut down. And now when they walked, they were ready for even a 4th ankle sprain really quickly. So my second patient is someone who comes into the office. This was an elderly patient, a little older than me, but not by much. And they walked into the office with some medial shin and ankle pain. And it was very obvious at the cursory examination that they pronated a lot more on this left side. So again, okay, so now the first example was supinators. Here's a pronator example. So the typical reason for that in an elderly patient is posterior tibial tendon dysfunction until proven otherwise, right? But on my exam, I found the patient very strong, and the posterior tib was strong, and it was also not painful. And then there's always biomechanical asymmetries. Just because somebody has a forefoot varus on one side, they may have a forefoot valgus on the other side. Just because they have external tibial torsion on one side, they can have normal tibial torsion on the other side. So we're looking at the what was a reason that just the left side was breaking down. This patient had a higher external angle of gait on the left side, which was producing more pronation. It turned out it was a longer leg on that side, and which about 80% of long legs compensate by more pronation on that side. It's a pretty good general rule, but 20% of people, it's the opposite. So it's just a general rule. They actually had a very tight, Achilles tendon, which adds to that pronation problem. And here's the foot that's externally rotated on the left side. as they walk, it pronated. So the answer for this patient, the reason biomechanically for this asymmetry was they had a more external angle of gait because they were developing hip pain. In fact, I was the one on this patient that made the diagnosis of, I said, why is she doing this? And I looked at her hip motion and she had no internal rotation at all. And that's one of the signs that the hip is becoming arthritic. And, you know, a lot of people just like, okay, I'll just limit my activity. This person ended up with a hip replacement. There was more pronation on the left, and it was 3/4 of an inch short. I'm sorry, long on the left side, but short on the right side, and that was due to an old skiing injury where they had a tip fib fracture 35 years ago on the right side, which it could have always been longer on the left, but that probably added to it. And only the tight Achilles tendon was found actually on the shorter side, not the longer side, so it was not a reason why they pronated. There was a significant forefoot varus on the left, which was reduced when I manipulated prior to casting her foot for orthotics. So it was really a supinatus. I do manipulations for my forefoot varus patients prior to casting. It's pretty easy just to do a few torques of their foot. It usually takes away some of the forefoot varus angle, which is really supinatus. So anyways, that was a very interesting case. That really, it was a long leg breaking down the hip. The hip was externally rotating. That rotation caused more pronation, and we had to shore it up with an orthotic to help so the treatment for this person was an orthotic, of course, for both sides, but more correction on the left, and a hip replacement. You know, and I was the one directing, you know, this patient. I said, you got to see an orthopedic surgeon. You got to get this hip done, or at least looked at. At least somebody smart telling you. Okay. So anyway, that was fascinating. And this is not that common a problem, but I do see it probably a couple times a year. Patient walks into the office and they have pain in the ball of their foot around the sesamoids, and they also had some sore hips with walking. Very active person, still trying to do a lot, so couldn't sort of do a lot of walking, so was biking a lot, was elliptical a lot. So the gait was antalgic and apropulsive. And again, what would be the common thoughts? So pain in the ball of foot is sesamoiditis with overpronation until proven otherwise. That's my sort of my rule. I want to know what those sesamoids are doing. Even if they point just to the top of the big toe joint, I want to know what the sesamoids are all about. And some sort of hip flexor tendinitis was found. So the patient was shuffling because of I thought they were just shuffling in the office because they had pain. I didn't see any pronation or supination. They're sort of a neutral foot. So you know, that was, but I didn't pick up on why they were shuffling. I thought it was just because of an antalgic gait. So my rules of thumb with athletics is that I want the patient to be able to do 2 minutes of a single leg balance. And if not, I have them work towards that. That's just a great strengthening thing for the whole leg. I want them to do 25 25 one-sided heel raises. That's the gold standard for a strong Achilles tendon. But I didn't have the person do that because their sesamoids hurt. And the sesamoid hurt, and I just didn't want to stress it, so I missed it. They did have a sort of a met rectus foot, a hallux limitus type of foot. They did have a plantar flex first ray with a rigid, although they didn't really supinate a lot. I didn't see a supination problem with this person. Maybe because they were just sort of plopping along. So it was a plopper, whatever that medical term is. I found that their hip flexors were strong but very sore on muscle testing. So I just had them do some stretching exercises for the hip flexors. No big deal. The biomechanics showed no indication of overpronation, so that they weren't an overpronator. They were picking on their sesamoids for sure. Now the history. So sometimes I get I'm getting a history of what happened to them at the point, of what caused their injury. But a lot of times I hear in other visits, oh yeah, I hurt my Achilles tendon years ago. I had surgery on my Achilles. Sometimes that comes out. It doesn't come out on the initial exam. They don't mark it on we have a form that you're supposed to write your old surgeries down on, and they didn't write it. So this is one I didn't get all the information. I didn't test for all the information. It took a while to figure it out, but it was fun when we did. So basically, this person had an old, instead of it was a right ball of the foot, but the old left Achilles tendon had been torn, and they had surgery on it, and only recently had an increase of activity from their desk job because they had a new grandchild that they visited, and he wanted to be a good grandpa. So here's the patient with the Achilles tendon surgery on the left side. Here's a patient who should be able to do 100 single heel raises or double heel raises and at least 25 single heel raises, and they couldn't do one. So what happened with this patient, and I'll finish with this. So the patient had torn, from what I could gather, the patient had torn their left Achilles and had never, even though he had surgery, never regained the strength. I think it all scarred in, the gastroc and soleus fibers all scarred down. At the time of the injury that I saw, he could not do one single heel lift on either side, not one. So the Achilles surgery was years before, so he'd been shuffling around and just working like a son of a gun. I don't know what the Spanish phrase would that be, but he working really hard, ignoring his health because he knew his Achilles tendon wasn't very good until he got his grandson. I have a wonderful grandson, Henry. So I could see this happening. So and this was not discovered till many visits into my rehab. So the apropulsive gait was related to no heel lift due to the severe Achilles weakness. Shuffling gait irritated the sesamoid since the big toe was also set up. I think biomechanics, if you have pain in an area, your heel, your ball of your foot, it has to be, I think it has to be related to about three things. It's my rule of thumb with biomechanics. I always look for not just one thing. I just don't blame something on pronation. I want to see like pronation and something else. So the apropulsive gait was really due to this severe Achilles weakness. The reason the big toe got picked on was that there was this plantar flex first ray, which set up an irritation on the sesamoid. It's lower than normal, and also the person couldn't bend the big toe, so you spent a lot more. The big toe spent a lot more time on the ground, and not the forces. As you bend a joint, the forces are dissipated in that joint. This person actually was slowly developing more and more hallux limitus or rigidus. Had a rectus foot anyway, if you look back on my initial part. So had a rectus foot, which is sort of predisposed for hallux limitus and hallux rigidus. So anyway, so there was a lot of reasons that there was more stress in the big toe area. And then, of course, the reason the patient hurt their hip flexors is that they were using their hip flexors to clear the ground like you would do with the steppage gait and a drop foot patient. A lot of people, they just lift their hips up, and since they're apropulsive anyway, it's a subtle thing that, again, I didn't pick that up either initially. So it was like the fourth or fifth visit I said, aha, I know what your problem is. And then we started really rehabbing them. I looked at my notes prior to this, and the last time I have a note, one, he's fine, but two, he was up to 17 single leg heel raises, and had a lot of therapy to break up the scar adhesions in there. The Achilles tendon was all bound down. It was a mess in there. We were trying to avoid another surgery to clean out the area, which could have happened. I don't think it will. So anyway, I hope, David, thank you. I'm honored for being invited to do this. To all my Spanish podiatry friends, please stay safe, and we will get through this. I hope this was a good, 3 simple cases that each showed just something a little bit more complex about biomechanics, but it's rare that somebody comes in with a real simple problem, and if so, there's few of those. But if you're in a biomechanics practice, these are the patients you just love to see.
Thank you.
So
thank you,
thank
Richard.
you so much.
Thank you, Dr. Richard. I'm sure everyone could learn something new from your answer. So the last question is if you can send an encouraged message to our community podiatry world. Okay.
The message is that everyone stays safe with this coronavirus, and I hope we'll all get together again. Life will get back to normal. I hope that biomechanics is something that you grow with and can get very skilled at helping your patients, because really only podiatry is a profession that's really helping people in a biomechanics way, putting it all together. Pongamos el monde de pie.
Perfect. Thank you, Dr. Richard.